Hey everyone, welcome to Taking the Pulse, a healthcare and life sciences video podcast. I am Heather Hoops Matthews, here today with Maynard Nexon healthcare attorney Lauren DeMoss. Lauren, good to be with you.
So great to be here, Heather.
Lauren and I are coming to you live from SCBIO's annual summit in Greenville, South Carolina. It's one of the Southeast's leading life sciences conferences with cutting-edge presentations and national life sciences leaders. We are so thrilled today to have Tim Dall join us. Tim, thank you.
Thank you.
You are a healthcare economist with over 25 years experience studying the economic burden of chronic disease and the value of treatment and prevention. That is a heavy topic. But recently you have been currently the executive director of GlobalData PLC, which has partnered with Eli Lilly, and you've been looking at obesity. Tell us why these two entities came together to focus on this topic.
Many pharmaceutical companies like Eli Lilly are very interested in the topic of obesity, in part because they have a treatment option. And many people, in the national level, when you see people talking about obesity, often it's like, how can we afford this treatment? We have so many people that need the treatment. It's not cheap. We just can't afford it. And so one of the things we're doing is looking at what is the cost of not treating, because it's a very high cost to do nothing. And then also the cost is not as much as what people might think. For example, if you look at first of all, we classify obesity according to a body mass index. We put people into these different categories like class 1, class 2, class 3, depending on how severe their obesity is. And it's well documented that obesity increases the risk for type 2 diabetes, cardiovascular disease, various cancers, musculoskeletal. I mean, it's a whole host of conditions, right? And because of these conditions, people are more likely, if you're employed, to miss work or to show up at work and be feeling sick and your performance is lower. There's higher healthcare costs, both to the employer and the employee. People with obesity are less likely to be in the workforce. They earn less. There's all these economic costs associated with obesity. And people only look at, well, what is it going to cost to treat them? And they don't look at what does it cost to not treat them. And so that's what we've been doing. And then in addition, many of the studies that have been done, and there's quite a bit of research out there, look at things from a national perspective. But if you're an employer and you want to understand what is the potential return on investment to some kind of a program among my employees and covered dependents, I don't really need to know what's going on with Medicare and Medicaid. I need to know it from my perspective. So we've been doing a series of state studies where we look at it from the perspective of state government and the state economy, and some employer-related studies where it looked at things from the perspective of employer.
When you think about, let's talk a little bit more about workforce development and obesity, because as you mentioned, that's an issue. What trends are you seeing as corporations try to handle either, obesity leads to other chronic illnesses and employees having to take extended medical leave or any sort of, retention requirements or retention kind of issues that relate to obesity in the workplace? What trends are you seeing folks trying to handle that?
Sure. Well, the one trend we see, of course, is that the obesity prevalence rate has been increasing. And right now at the national level, you can kind of put about a third of the population, the adult population, has a healthy weight. About a third has overweight, and about a third has obesity. Okay, so about a third. In South Carolina, where we are, it's a little bit more on the obesity side. Some of the southern states, we talk about, the high rates of obesity and cardiovascular disease and diabetes in kind of the southern states. But for employers, you do see this rising healthcare costs that are associated with obesity and other factors. And employers have a vested interest in trying to control costs. Because if they don't, they're less competitive. And also, as healthcare costs have risen, employers have tried to shield their employees from these rising healthcare costs by maybe subsidizing more of the healthcare premiums. And what that means is that there's less money to go into wages. And so we've seen over the past couple decades that wages have really stagnated, in part because the employers are trying to shield them from the higher cost of healthcare. And for some occupations that are maybe lower earning, it's particularly difficult because they're trying to put food on the table.
Right.
Yeah. So in the work, you think of wellness programs that employers implement to manage chronic illness, obesity, incentives for employees. I mean, what you're doing, that's more than that, or it's enhancing kind of this, the wellness programs were very kind of big and new, maybe a decade ago, but this is more than that, right?
Right. Well, in our reports, which are online, we put out a series of recommendations to government policymakers and recommendations to employers. And for both the employers and the state policymakers, the first recommendation is to understand that obesity is a disease, just like diabetes or heart disease. It's recognized by the American Medical Association as a disease. But there's a lot of misconceptions and a lack of parity. So for example, if someone said, should we cover cancer? Or should we cover diabetes or heart disease in terms of medication and access to care? People say, of course. But when we say, should we cover obesity? A lot of people say, well, that's a behavioral thing. They're making choices, and those choices are leading to obesity. And while for some people that might be true, for many people, their body prevents them from losing that weight. And so, first of all, to understand that obesity should be treated with parity with other chronic conditions as a disease. In terms of wellness programs, that's another area where many firms are doing work in this area. It's sometimes hard for them to track kind of the return on investment because they're unable to tie participation in a wellness program to someone's actual medical records to quantify, okay, this is the impact. But we do know that they do work. And, when you think about people with obesity, about a quarter of the people with obesity, all they need to do is lose a few percent body weight. With 5% body weight, you could move a quarter of the people out of the obesity category. And that's just improving your physical activity levels, some improvement in your diet. And there's things that employers can do. For example, when we think about let's have a team meeting, we all gather in the conference room, we sit around a table, and we talk, right? Why not just go for a little walk? But of course, to do that, you need some walkable spaces.
Right.
I worked for a healthcare consulting company a number of years ago, and every Tuesday they would bring in cookies. And they weren't just little cookies, they were humongous cookies. Right. I think they're made out of lard, and they were so delicious. And I think 20 years later, I'm still carrying those cookies with me. And then someone said, we're a healthcare consulting company, we should maybe have some healthy choice options.
Right.
So next to the cookies, they had a veggie platter. And you'd go in there and all the cookies would be gone and the veggie platter would be untouched. Mm-hmm. So there's some things that we can do to change the culture, right. Wellness programs, and then of course, access to actual formal medical treatment.
Right. Kind of a basic question for you. Help me understand what is obesity? Like what is the definition, the percentage that you talked about? And then why do you think southern states, it's higher in southern states?
Yeah, well, I'd say it's probably the good cooking in the southern states.
Okay.
But yeah. So we measure what's called a body mass index, where they take a person's height and their weight, okay. And they put it through a formula. And if you have a body mass index of 30 or higher, then it's considered obesity. And then between, so that's the main thing. Yeah. You get into other categories like class 1, class 2, class 3. And when we look at treatment options, like for bariatric surgery, we're looking at usually a body mass index of 40 or higher, unless you have chronic conditions, in which case it might go lower. But it's an imperfect measure, but it's a very simple measure. And because it's simple, a lot of people use it. But it creates some issues by defining obesity that way, because you can have people, maybe that they're in an occupation where they're very physically active and they're muscular. And it will say, well, you meet the definition of obesity, but really they just have a lot of muscle and dense bone structure, right? So it's an imperfect measure, but it is very highly correlated with the onset of type 2 diabetes and heart disease and other chronic conditions, and also a good measure that people in the obesity category have much higher healthcare expenditures compared to people with healthy weight.
And you mentioned earlier, I'd like you to expand on it, that there's a particular impact on vulnerable populations.
Right. Well, and that happens for several reasons. One is minority populations tend to have higher prevalence of body mass index or higher prevalence of obesity. And this is in part tied into socioeconomic factors. For example, if you go to the grocery store and you look at the most healthy foods and the least healthy foods, the most healthy foods are usually much more expensive, right? You look at the cereals, expensive ones, $9 a box, yes. Cheap ones full of sugar, $3 or $4 a box, right? And you also have what we call food deserts, where in some communities, in particular in inner city areas, where there might not be a lot of grocery stores close by, but there's a convenience store, there's a McDonald's, and some of these fast food places, you can get a lot of calories for only a few dollars.
Right.
And so those are all things that contribute to it. But we also see that women are disproportionately affected because of obesity. For example, when you look at earnings, and you correlate that with your body weight and control for other factors like age and so on, what we find is that women with obesity earn 9% less than women with healthy weight. Men with obesity, they earn the same as men with healthy weight. There's no difference for men, but for women, for whatever reason, they earn less. And of course, this just increases the pay disparities that already exist. Likewise, both men and women with obesity are less likely to be in the workforce than their peers with healthy weight. And for women, the impact of not being in the workforce, or the probability of not being in the workforce, the obesity impact is 3 times as large as it is for men. Again, we don't really understand why. It's probably a combination of factors. It could be occupation and industry choice, factors. It could be biases. It could be mental health related. We don't really know.
Right.
What kind of trends are you seeing? You mentioned, the walking to the meeting and offering healthy snack options, but also, you mentioned going and, advocating to have certain weight loss kind of things covered by insurance, or they're supporting someone who is obese and want them to kind of engage in some sort of weight loss. What do you see in terms of trends, i.e. drugs being covered by plans that promote weight loss? And do you have any sort of predictions for the future, just how this will evolve?
Sure. Right now, there's new drugs that come out called GLP-1s. It's a new anti-obesity medication, and they're, when you look at the list price, they're fairly expensive. And so you'll see employers and state Medicaid programs and Medicare that will say, we can't afford it. We have too many people, and it's too high a cost. And so there are more and more employers that are covering these newer medications, and also some state Medicaid programs, and some states are starting to cover them for their employees that are covered by a state health insurance program. So that is on the uptick. But when we look at trends, if you go back a couple decades when statins came out to control for cholesterol levels and antihypertensive medications, it was the same story. We have so many people that need them, and they're so expensive, they'll break the budget. We can't afford them. And now, over time, more medications and treatments come on the market.
Right.
The pharmaceutical companies, they lose their exclusivity, and generics become available. And now people don't even really talk about the price of statins and antihypertensive medications. They're almost, I wouldn't say handed out for free, but
right.
They've just become a way of life. I think this is what's going to happen with obesity treatment. Right now, there's a focus on cost, but that won't last very long, and prices will come down. And I really think that there's a lot of reasons to be optimistic about the future for obesity treatment.
Well, and you think of a cost-benefit analysis of, it might seem expensive now, but if someone's able to successfully engage in something, the other comorbidities, chronic illnesses that you mentioned, it might keep those things from being an issue and a further cost in the future.
Yeah. Well, our research in our report on employers is still a couple of weeks away from being published. But we estimate that employers and employees are incurring costs over $6,000 per employee with obesity. This is higher medical costs, lost productivity, missed work days because you're sick, and there's some other factors, disability, workers' compensation costs. And so if you could address the obesity issue, those are some costs that would largely disappear, right? Mm-hmm. But right now, the price of certain types of treatment might be even a little higher than that. But that doesn't take into account the improved quality of life. Not only is a person less likely to experience onset or severity of chronic conditions, obesity is well tied into the mental health issues. So there's the quality of life implications. We hear these patient stories when we go to these conferences. They often have a patient talk about it, and it sometimes breaks your heart. It would be like a mother saying, I want to play with my kids. They want me to go to the park and run around with them, but I just physically can't do it. And so the very heartbreaking stories. And then in South Carolina, we have, let's see, what are the numbers? About 8,800 people in South Carolina that die prematurely each year attributed to obesity. Now, about half of those are of an age that they would have still been in the workforce.
Whoa.
So some of them are older, some of them are younger.
Right.
And so that is an impact on the economy. So when we look at South Carolina, what we estimate is that in a hypothetical scenario where there were no obesity in South Carolina, the economy would be about $7.4 billion higher per year than it currently is. That is, the state's gross domestic product is about 2.5% lower than what it would be if we could eliminate obesity in the state.
That should get some attention.
I was going to
Yeah.
say,
Yeah.
yeah.
And we estimate about $909 million on the state budget impact. Yeah,
That's significant.
So we've got higher Medicaid costs. So if you look at South Carolina's share of Medicaid costs, they're higher by almost $172 million per year just because of the higher prevalence of obesity among the Medicaid population. And this is just the state share. That's independent of the federal government share. We have about another $168 million in higher healthcare costs that the state and local governments pay for the insurance of their employees and covered lives. We have higher, because people with obesity are less likely to be in the workforce, they're more likely to be on public assistance programs. There's higher costs there. Because they're less likely to be in the workforce and earn less, and there's productivity implications. There's implications for for income tax revenues, sales tax revenues, corporate tax revenues. So altogether, this is about a $909 million per year impact on the state government.
So employers need to think very broadly.
Yes.
In terms of the impact.
Where could someone find your stats?
So we have fact sheets and reports for 5 states that are online,
Okay.
and we have another 25 states whose reports will be coming online over the next year.
And that's they just go to GlobalData
Yeah.
website.
So if you go to GlobalData.com/health economics.
Great.
Well,
Tim Dall, 25 years in this area, you can tell that you know it well. And clearly that's a topic, impactful economic topic, but more so just a heart topic to help people. Thank you for joining us today.
Well, thank you.
On behalf of Lauren and the whole Taking the Pulse crew, thank you. And thank you to our viewers. We hope you enjoyed this episode of Taking the Pulse. Again, you can go to globaldata.com/health and find out more about maybe what's happening in your state. And we look forward to seeing you next time right here on Taking the Pulse, a healthcare and life sciences video podcast.